Hello, my name is J. Radhakrishnan, and I'm a nephrologist at the Columbia University Medical Center in New York. I'm also the clinical director of nephrology. We have a center at Columbia called the Center of Glomerular Diseases, and we take care of people with rare diseases like IgA nephropathy. And to achieve our sort of goals in treating patients in the best way possible, we combine not only clinical examination, but we have world-class pathologists and a genetics center that all come together to help patients with IgA nephropathy. And not only that, we are involved in clinical research. We are a testing site for novel therapies that are now appearing with pretty amazing regularity in the space. For example, there's no therapies beyond corticosteroids as late as 5 years previously, and now we are in the setting where multiple therapies are now available to treat our patients. So IgA nephropathy is a rare disease. So the approximate incidence, in other words, new patients coming in with the diagnosis is between 2 to 10 per 100,000. So in the United States, there are approximately 200,000 people who are living with IgA nephropathy. And unfortunately, many of them are not diagnosed because it takes a urine test to suspect that the patient has IgA nephropathy. And following the urine test, there is a need for the patient to be referred to a nephrologist who would then perform a kidney biopsy. And that biopsy is essential because there are no blood or urine tests that specifically provide the diagnosis of IgA nephropathy. So the patient's journey is quite varied. The fortunate patients are diagnosed early when a primary care physician or an insurance exam performs the urine test, and that leads to ultimate diagnosis based on a biopsy. But unfortunately, the majority of patients who present have not been diagnosed. And the main reason is that urine testing is not a standard of care in a normal population. So these patients present with advanced kidney disease and many times actually needing dialysis or transplant at the very first instance of nephrology referral. So there's a big gap in terms of getting people to early diagnosis in this disease called IgA nephropathy. So unfortunately, the very early phases of the disease, the patients have absolutely no symptoms. It's only as the disease progresses, which is kind of late. You have fatigue, you can have a swelling of your legs, and someone might notice that your blood pressure has shot up. But the key red flag that I would say is if there's any sign of, for example, a blood pressure that's been noted for the first time in a young person, or if on a routine physical exam, the physician does do a urine analysis and finds blood or urine, that's really the only way you can diagnose this disease. So very early in the course of the disease, it's very, very difficult to diagnose based on symptoms. This is a very complicated question. What is optimal management? And we have a guideline committee of which I was a part of called the KDIGO, guideline on IgA nephropathy. And this was first published in 2021, and it's just been updated the last month because of the newer therapies. So it's very clear that there has to be a discussion between the patient and the prescribing physician. And the conversation will go something like this. So you have IgA nephropathy, and this carries a lifelong risk of progression of kidney disease and kidney failure. And it's very important that we closely follow the kidney parameters. And this does need sequential testing at intervals that needs to be determined based on the severity of the disease. Now, what is important is that the patient has to follow from a lifestyle standpoint, a heart-healthy diet, low salt, exercise, which is universally applicable, but especially so for this disease because it does magnify the effect of the disease on kidney damage. So if you're not following a good lifestyle, you're going to get much more severe disease compared to people who are following a healthy lifestyle. We need to control cardiovascular risk factors. And then we focus on the damage. Okay, so there are two sides to the equation. IgA nephropathy is an inflammatory disease. It's an autoimmune disease. So your body is producing antibodies that are not normal. And these are produced mainly in the gut. And they come into the system and then they deposit in the kidney. They form what's called immune complexes because these antibodies are since they're not normal, the body forms antibodies against these antibodies. And the resulting immune complex goes and deposits in the kidney. It incites an inflammatory response. And that leads to scarring in the long term. So this may not happen for the first 5 or 10 years, but if you are not treating the disease adequately, the fibrosis or scarring that's irreversible essentially is going to lead to kidney failure over time, right? So our focus is on the inflammatory side. There are new drugs. It used to be that corticosteroids were the only drugs available for the longest, but now we have what's called targeted release corticosteroids, because these are pills you swallow and they selectively knock out the cells that are making the abnormal IgA in the gut. And very little of this steroid is absorbed. So it leaves the effect quite prominent, but you don't get the side effects of absorbed steroids that prominently. And the other drugs that are now being released in this space are, for example, drugs that block a molecule called endothelin, which is released in IgA nephropathy patients, and it leads to damage to the blood vessels, and also it increases the degree of scarring from any stimulus, for example, inflammation. And the third group that has now been recently approved is a drug that blocks a protein called complement. And what complement does is that it amplifies the inflammation. So in people who've got these immune deposits in the kidney, there is activation of this protein called complement, which leads to the magnification of the inflammatory effects of this protein deposition. So if you can dampen down this inflammation by blockers of the complement pathway, that also leads to reduction in proteinuria. And this drug has been recently approved, but we are waiting for the final approval because there are two steps in the approval process. The first is to drop the urine protein, and then you got to show that the kidney function decline is stabilized with these drugs. So, IgA nephropathy is a very rare disease. So my recommendation is that we first need to diagnose it, in a timely fashion. So if there are any of these so-called red flags, like a blood pressure that's, unusual for a young person, or there's any trace of protein or red blood cells in the urine, it's best to refer them to a nephrologist who can then do the biopsy if it's indicated to, make an early diagnosis. And that's the critical part in the proximal part of the healthcare system, is that early referral is the key. And once the patients are referred to a nephrologist in a timely fashion, then we can institute, therapies to slow the progression of this disease in a meaningful fashion. And it's a little complicated because every patient is different, and we cannot have the same cookie cutter approach to treat all patients. There's no real protocol to treating patients, and there's a lot of nuances in the treatment. How old is the patient? What is the comorbid conditions like diabetes, hypertension, and other such disease diagnoses which the patient may carry? Does a patient have a very high BMI, which may make them very susceptible to certain types of immune agents? What is the degree of inflammation? How scarred the kidney? So all these factors play into the equation on how best to treat the patient. And what is also very important is this snapshot changes during the lifetime of this patient. So what they present with and what they have 10 years down the line may be completely different, mandating a change in the therapeutic approach. So the other thing that we very much like patients to participate in is clinical trials, because the way we reach or arrive at this point is due to the generosity of patients who participate in these clinical trials. And as a result, these new drugs became available. So this is a shout out to patients out there saying, look, if you have a rare disease, for example, IgA nephropathy, please participate in clinical trials, because there's almost a certain chance that you'll actually get the drug even if you're on the placebo arm after a certain length of time at the end of the trial.